Welcome to The Explainer. Today, we're diving into a really tough spot for anyone in the NICU. You've got a sick newborn who looks septic, they're not getting better, and you're starting to wonder, what else could this be? We're going to walk you through a clear, systematic way to answer that question. Could this be an inborn error of metabolism? So here's our game plan. First, we'll talk about why these cases are such head-scratchers, the so-called great mimicker. Then, we're going to bust some common myths that can really get in the way of a diagnosis. After that, we'll give you a super simple, staged approach you can use, apply it to some common lab patterns, and then wrap it all up with an initial action plan you can literally take with you on your next shift. All right, let's jump in. The biggest hurdle, honestly, it's just having an inborn error of metabolism, or IEM, on your radar in the first place when you've got a crashing newborn in front of you. We have all been there, right? You've got a sick baby, and every fiber of your being is screaming, infection. The sepsis workup is underway, you're hanging antibiotics, but that's the exact moment you need to pause and ask that question. And this is so important. The metabolic workup isn't something you do after you've ruled out sepsis. It should really be part of your initial thought process. And get this, a baby can have documented sepsis and an underlying IEM. In fact, some conditions, like galactosemia, actually make them way more vulnerable to nasty E. coli infections. They're not mutually exclusive. So what are you actually looking for? Well, that's the tricky part. The symptoms are super vague. You'll see a baby who is totally fine, and then usually after that first 24 hours of life, they just stop feeding well. They get irritable, then kind of floppy and hypotonic. Maybe there's some vomiting, maybe a seizure. It's this scary, fast spiral down into lethargy, and sometimes all the way to coma. That whole cascade, that is your classic picture of metabolic encephalopathy. Okay, so before we get to the nuts and bolts of the how-to, we've got to talk about the mental roadblocks. There are a few big myths out there that can really trip us up and keep us from even thinking about an IEM in the first place. This one's a biggie. We're all taught, when you hear hoofbeats, think horses, not zebras. So we assume IEMs are these incredibly rare things that should be at the very bottom of our differential. But is that really the right way to think about it? Well, here's the reality check. Sure, any single metabolic disease is rare. But if you group them all together under one big umbrella of IEM, suddenly they're not so rare at all. As a category, they're actually a surprisingly common reason for a newborn to get critically ill. It's just a small mental switch, but it makes a huge difference. All right, myth number 2, the sheer number of them. You hear inborn error metabolism, and your brain just kind of short circuits thinking about all the different pathways and enzymes. It feels completely overwhelming, like you'd need to memorize a textbook. But here's the secret, and it's a huge relief. You don't have to. So many of these different diseases present in very similar ways. There's a ton of overlap. That means you don't need an encyclopedia in your head. You just need a good system. A couple of simple algorithms can help you tackle the whole category. And the final myth, that this whole thing is just way too complicated, that you need to be a metabolic geneticist to even begin to figure it out. But that's just not true. The key is a staged approach. Start broad, then narrow down. Your job on the front lines in the middle of the night isn't to pinpoint the exact enzyme deficiency. Your job is to spot the red flags and get the ball rolling with some basic initial tests. That's it. You can absolutely do that. Okay, so hopefully we've cleared away some of that mental clutter. Now let's get to the good stuff, the practical step-by-step framework you can actually use at the bedside. It really boils down to a 2-step process. Step 1 is all about using the tests you already have at your fingertips. The fast, cheap stuff that every hospital lab can run. The only question you're trying to answer here is there a metabolic fire burning? If the answer is yes, then you move on to step 2, which is sending off the more specialized, confirmatory tests to figure out the exact cause. So what does step 1 actually look like in practice? Let's walk through how this works with a couple of the most common lab abnormalities you're going to run into. First up, hypoglycemia. We see low blood sugar in the NICU constantly, right? But what we're talking about here is different. This is the baby with a glucose of like 10, or the one you're pouring D10 into, and that number just won't budge. That kind of hypoglycemia is a massive red flag. So you've got that hypoglycemic baby. What's the very next question you should ask? It's super simple, and it creates this perfect fork in the road for your diagnosis. All you need to know is, are there ketones in the urine? And this is a fantastic clinical pearl. If your blood sugar is low, your body should be burning fat and making ketones for fuel. If it's not, if you have hypoglycemia with few or no ketones, that points you straight toward a fatty acid oxidation defect. The baby literally can't use fat for energy. Just like that, your list of possibilities gets way, way shorter. Okay, our next big signpost is metabolic acidosis. Now, yeah, most babies with an acidosis are in shock from sepsis or have poor perfusion. But if you see a baby with a really nasty high anion gap acidosis and their perfusion seems totally fine, you have got to think about an inborn error, especially something like an organic acidemia. And just like with hypoglycemia, you can use your other basic labs to start sorting things out. You just ask a series of simple questions. Is the baby also hypoglycemic? Are there ketones? Is the lactate sky high? And what about the ammonia? The answers to these questions start to separate the different big categories for you. Is it an organic acidemia, a lactic acidosis, or maybe a urea cycle defect? All right, let's tie this all together into a real action plan. You're at the bedside, you have that sick, septic-looking baby, you're thinking, could this be an IM? What do you actually order? Here it is, your first-line metabolic toolkit. It's basically 5 core tests that you can get back fast. A blood gas to look at the pH, a lactate, a glucose, a plasma ammonia, that one's key for urea cycle defects, and a simple urine dip for ketones. That's your starter pack. With just these 5 results, you can cast a really wide net and get a fantastic first look at what might be going on. So, to recap the action plan, number 1, always keep your suspicion high in any neonate with that weird sepsis-like picture. Number 2, use the staged approach. Start with those 5 basic rapid screening tests. Number 3, learn to decode those key patterns using glucose, ketones, ammonia, and pH to guide you. And finally, never forget, a baby can have both sepsis and an underlying metabolic disease. And that leaves us with a final thought to chew on. As our newborn screening panels get bigger and better, we're catching more and more of these conditions before infants even get sick. It really makes you wonder, what's it going to be like in a few years when these once rare diseases become just a routine part of our daily practice?